Welcome to episode 3 of Antidotes. Last week was dark, to say the least. This week is not. We talked about EMS shit for the last 2 weeks, and now we're going to talk about some nursing stuff.
So I am here with my cat Frank, who is 15 years old and who normally ignores me, is currently sitting almost on the laptop because he hears someone else's voice and he wants attention.
He thinks he's going to be on the podcast.
He does.
Mr. Hyper or Hypothyroid Cat.
He is a hyperthyroid cat.
Yeah,
he's got heart failure and liver disease and kidney disease and like a stage 4 heart murmur and, just about everything. But he's still kicking, so.
Did you take him to a cat cardiologist? My aunt just did that.
I did not. I was going to, but it turns out kitty echoes are like $500. So,
That's still a better deal than human echoes. I would take a unloved relative to a cat cardiologist and just, take the discount.
Hey, if they're any good, yes. Well, I'm here with my 15-year-old disease-ridden flabby tabby.
Oh, I hope no one calls me that when I'm old.
Well, he's a tabby cat, so he's a flabby tabby.
He's red-haired too, and I'm pretty blonde, so.
Right.
I think I'm looking at my future when I'm looking into Frank.
Listen, Frank has like the best life ever. This cat, he gets meds twice a day. I buy him like this super special gourmet food that's like $2 a freaking can. James
does not buy me $2 a can food.
Yes, well,
let me tell you.
Yeah. For the amount of food this cat eats, that's like eating like $20 meals twice a day. What does James say?
He's living it up. I always said that if I believed in reincarnation, I would want to come back as Lowell, but living with you.
I remember.
Not living with me. All right. So this is going to be episode 3, where we talk about nurse shit.
Nurse shit.
And not EMS shit like previously. Those are the medical terms for these things. Yeah. This week, we have on Angela.
Hi.
And again, this is one of my friends. This is a podcast where I convince the world that I have friends. Because every week we talk to people that I know.
Right. You just sucker us and we feel obligated to come on your show,
Well, joke's on me. It's going to be a rotation of 3 people every single time because that's all I know. No. Oh my God, that'd be terrible. That'd be an awful podcast. So Angela and I met in the Army reserves. That's a big emphasis on the reserves. James, who was in real Army, is nodding and stamping his feet that I need to emphasize the reserves part of it.
In defense of the Army reserves, so I couldn't quote you exact statistics, but like something like 70% of the Army's medical corps is in the reserves because we have people that work as nurses and doctors and surgeons and, all the other support services that we never mention enough, like respiratory therapy, PT, OT.
That I can't think of off the top of my head.
Oh, yeah. All the other ones, like, listen, you guys, you're out there, the OR techs and the CNAs and the, all the other forgotten support services that just don't get recognized enough. But so they work in the best hospitals in the country, especially, up where I live. And then on the weekends, they put on uniforms and we play Army. So James can roll his eyes all he wants and talk all the shit he wants, but Army Reserves Medical Command is no joke. So
yeah, this is very true. Active duty medical soldiers, we're not shitting on them, but when they're not deployed, are treating soldiers and their families who are generally pretty healthy. Us shitty reservists and National Guardsmen that people like to make fun of, we're going into the city hospitals where we work normally and treating gunshot wounds and car accidents and the 80-year-old with diabetes and heart failure. And
it's kind of the best of both worlds. Get a lot of civilian experience. Civilian hospitals are fantastic.
Yeah. And so not to sound too much like recruiters, but
of course not.
That's how we met. But when you are 2 women in the military, especially 2 NCOs, you either become very quick friends or you cannot stand each other.
Right.
Because you spend a lot of time together. You go, all right, you also have a uterus. and you have boobs and you have stripes on those boobs, we are going to get roomed together. We are going to be assigned to do everything together and police up all the other females, especially the lower enlisted, junior enlisted. So please don't suck. Please don't be bitchy.
Yeah. Yeah. We were kind of made to be friends by force, I think. We were just kind of forced into our friendship. But it worked out, I think.
It did work out, I would say, many years later. And one of the moments that really highlighted that was we were on a mission. And I say mission, we were on our annual training, which is, summer camp for the reserves. We were in the field. It was very rugged, very tough. And
is this when I earned that nickname?
Yes, so that was the story I was going to go with. But let me first describe our field experience, which is, of course, the toughest of the tough. We had an inflatable pool.
It was great. Yeah, it was awesome.
It was terrible. The air conditioning units only worked part of the time.
Right.
We really roughed it,
We did. The showers, we had showers, but they were cold.
They were in a tent, too. I mean...
They were. So it's not like we were outside showering with, trash bags.
It was so terrible. It was so hard.
It was totally like the army version of glamping.
Glamping, yeah. And I had this mosquito net over my cot that everyone called the pretty, pretty princess bed because it was just this white mosquito netting that totally looked like something out of a young girl's bedroom. So obviously this is not the field, but this is what they called it.
Didn't you also have like an inflatable air mattress?
Oh, I bought a pool floaty at the dollar store.
Yeah.
Like a long one that I slept on to make it more comfortable. Look, I'm blonde, not stupid. It was very, very comfortable. Anyways, so you were the NCO in charge of the section of the hospital that we were in for these war games. And of course, only having cold showers and terrible food and, everyone smelling. Everyone was kind of on edge and being grumpy. And some of the junior enlisted were being like, oh, she's got a bad attitude. And they didn't like being told what to do because, millennials. No, I'm just kidding.
I think part of the issue was that I also have a really bad case of resting bitch face.
So that's what they said about you.
Which is true. Oh. It's true. So
they said Staff Sergeant Angela has resting bitch face. And I said, I was there and I was like, actually, that's Sergeant resting bitch face to you guys. And so then I told you that, and that has become the joke that you are Sergeant resting bitch face. If you're going to, you have to be respectful.
Right. If you're going to give me a nickname, it's, make sure you get my rank right. So my nickname now is Staff Sergeant Bitchface. And, it's a title that I wear proudly. So, yeah.
There are much worse nicknames.
For sure. Absolutely. As long as you're going to be respectful about it,
So that was a terrible, not fun, well, we think it was pointless mission. But you actually went on a really cool one a few years ago to a totally different continent, not the middle of the country. And it was a humanitarian mission. So tell me about that.
Yeah, so this is actually, the United States Army actually does a lot of humanitarian missions. And so that was actually my second one. And I went to a country in Africa. So this country that we went to is predominantly Muslim, and polygamy is very common there. And, there are cultural norms that I kind of struggled with, but that's, their culture, which is fine. It was just not something that I think I was prepared for as much. So over there in this particular country, women are valued as child bearers. And so your worth is kind of determined by how many children you have and how many children you can have. So as a woman that doesn't have children, you're kind of seen as less than. And this is something that, we were told that I didn't just make this up. This is not my opinion. This is what, we were kind of told as part of our cultural briefing, and what we were kind of told by staff at the hospital is they explained why certain things were being done.
Going into a culture like that is difficult for anyone, but also very difficult for females that are like you and I, very educated. You're in nurse practitioner school now. You're a nurse. You also have a bachelor's, you were like me, you have 2 bachelor's degrees, went back to get a master's. We are females that were NCOs in the military. We were a very educated, very independent, we don't take shit from no man kind of opinion and culture that we grew up in. It's hard to walk into another culture like that and still be respectful, but that's definitely something you learn when
it's
you
hard
see these other
to,
cultures.
we were invited into this country. We were working with their military in a military hospital. We were not there to teach them or anything. That's, it was kind of more, we were just
Your guess.
we were guests.
You were
Yeah, we
guests.
were there to help out, and we were there to kind of like establish rapport, among other things. So, just because you disagree with someone else's culture doesn't mean that, that doesn't give you the right to be disrespectful or.
Yeah, of course. So tell me about the hospital. What were their facilities like? You had mentioned to me kind of before we were recording that this was their best hospital, the top of the line equipment for this nation.
I think here, after working so many years in hospitals here, I was kind of taken aback by the facilities they had. One might say that they were dirty and equipment was often rusty and broken. The power went out a lot. Like there was a couple of times we were in the OR where the power went out and we lost all the overhead lighting. So people would just pull their cell phones out and turn the flashlight app on their phones on, and they would continue the surgery by the light of cell phones.
Oh my God. I like
Yeah.
one HIPAA violation. I mean, not that HIPAA is a thing outside the United States. I mean, obviously privacy is, but
Right.
HIPAA is a US law. But not sterile?
Nope. And I'm thinking, I'm like, oh my God, what if one of these cell phones gets dropped into a patient? Because I don't know if you know anything about, and I'm sure you know this, but cell phones are really dirty. They're very dirty.
I don't think OtterBox makes like a surgical.
I don't know that OtterBox makes a sterile case, but if they're listening to this, like maybe that might be something that you consider in the future
for third world nations during
for wherever
during surgery.
Yeah, just in case you need to light up your OR with your cell phone. So yeah, a lot of the equipment was broken, dirty. They did not have the medications that we would expect here, and just the way that they deliver care is much different. It's a cash for service industry. So if you don't have cash, you don't get health services. So I remember watching a nurse. This patient needed blood work, so the nurse waited, and the patient went into their purse, got out cash, handed the cash to the nurse. The nurse walked across the hall to the lab, purchased phlebotomy supplies and a tube, walked back across the hall, drew the patient's blood, and then walked back and paid for the blood test. And that was, the patient was admitted. And so if you don't have cash, you're not getting that blood test. Just the way it is.
I can't even imagine. And, as a primary care provider now, we get harped on all the time for excessive costs. We don't want to order testing that we don't need. Patients always like, well, can you order this test and that test? And they want excessive things. And we try and explain, no, we don't really need that. But this country, you really do not get tests. You do not. You probably are not getting a lot of tests you do need.
Yeah. If you have the money for it, then you can get whatever you want. So as a result of this, cash for services system, a lot of times we would have patients that had gone without medical care for an excessively long amount of time. Like they probably should have had surgery to correct these, certain issues 20 or 30 years before they came in the door.
Oh, God.
So we would see things that, just kind of, here they would just blow your mind because you were just like, that. Why? How did that get so bad? And so going back to the, women as, our value being in our ability to bear children, we had a patient that came in and she had pretty severe uterine fibroids and she hadn't had them corrected because she didn't have the money. And so our surgeon looking at this patient was like, this needs to go. This whole uterus needs to go. It's a mess.
I just want to pause you. So for anyone that doesn't know, uterine fibroids are benign. They are non-cancerous. But they can get very, very large and they can be very painful. They can cause a lot of bleeding. They can cause hormonal changes. I actually had a patient not too long ago with one that was like 12 centimeters by 11 centimeters by, I think, 9 centimeters. And that was the largest one. There's multiple of them. And that was in the US. I mean, they can get very, very large. So I can only imagine unchecked uterine fibroids.
Right. So I did not see what it looked like before. I did see the uterus after when they were getting ready to put it back into her body. So it looked like, the stitches on a softball. It was like that, but the whole thing was like that.
So wait, explain the procedure. They took the uterus out. while she's sedated, remove the fibroids and then put it back? Or this was a procedure that was done years prior?
No, so while we were there, they I don't know if she was under local or like a spinal anesthesia, but I remember they kind of similar to a C-section. They make an incision, they remove the uterus from the body, from the abdominal cavity or pelvic. So they make an incision, they remove the uterus from the body, they remove the fibroids, and then sutured the uterus back up. And our surgeon, who I was working with, a U.S. surgeon, was like, I don't like this at all. I don't feel like this is good medical care. If she ever has a pregnancy, I don't know that this uterus is going to hold. I'm really concerned about the risk of uterine rupture. And I think she just needs a hysterectomy. But this patient was in her 40s and didn't have any children and wasn't married. And so if she, so if she were to have a hysterectomy, that would basically limit her marriage potential and really her potential in life, So she was not willing to have a hysterectomy.
You have to also think about, so she has this uterus, had surgery, and fibroids can be either inside the uterus, they can be in the walls of the uterus, they can be in the membranes, they can be kind of in different places. So who knows where they are, and the stability of the uterus. She's not going to probably have a very well monitored pregnancy. She's already in her 40s. That's a high risk pregnancy to begin with.
Right. Yeah, absolutely.
The risk of, complications and maternal and fetal demise from that is just so high. It's just really tragic.
Right. And to me, I think that kind of struck me because, and obviously this was not my opinion because I don't really have the education or experience to kind of speak to that level of like obstetric care. But the surgeons that I was working with were very concerned about that surgery. And it kind of struck me that, this patient and the doctors there were willing to forego kind of standard care in favor of preserving her fertility, because preserving her fertility would, preserving her, value as a woman.
And that was her decision as well. She was not forced to that.
No, not at all. But yeah, it was just kind of mind blowing to me as, yeah. So, and then, another incident, which I've told you, Christine, I've told you this, I think, a few times because it was, this one was kind of traumatic.
Yes, the other incident, which is,
I think, for a lot of us that were involved in this. So we had a patient who, I don't know the backstory. I don't really know what, why she was there. I do know that she came in for a hysterectomy.
So removal of the uterus and ovaries.
Yes. Like, I don't know why she was getting it, but if she was getting it, based on what I had seen previously, I'm going to go ahead and assume that she must have really, really, really needed it. So she, here in the US, we do most procedures like that under general anesthesia. So, the patient is completely put to sleep. They're paralyzed. Somebody intubates them and takes control of their airway.
Put the tube down their throat. It's intubation.
Put the tube down their throat, right. And that patient is out cold and they don't remember anything. I'm sure if anybody that's listening has had surgery, you've probably had it under general anesthesia.
However.
Yeah. So like I said, cash for services. So for whatever reason, they decided to do an epidural. And so she was wide awake.
Explain real quick what an epidural is.
Yeah. So I'm sure if you've ever seen any of the million shows where women have babies or, deliver by C-section, they put a needle into the spine and administer medication to numb the patient from that point down.
Right. Because you don't want a woman that's giving birth to be under general anesthesia. You want her to be awake and being able to push, not for a C-section, but for certain things you want her to be able to feel and then maybe begin nursing or interacting with the baby. She shouldn't be under general anesthesia. But you were there as a medic because this was before you became a nurse.
Correct. Yes. This is before I went to nursing school. So I was there as a medic. So a lot of what I did was honestly just watching. And because, I was not a nurse yet, a lot of the people I worked with took it upon themselves to explain things to me, which was fantastic. It was a great learning opportunity for me. So as a result, I got to watch a lot of stuff and learn a lot of stuff, and a lot of things were explained to me, which I thought was just, a great way to absorb everything that was going on around me. So this patient, she had an epidural, and they were going to perform a hysterectomy. And everything was going fine initially. They made an incision under her belly button and opened her up, and they started to remove her organ. And that's kind of where things got a little hairy. She started screaming in pain.
That's never a good sign in surgery.
No, it is not. She started screaming in pain because she could feel what was going on. And I imagine that having an organ removed is probably a pretty painful procedure. So
I would think any organ being removed is no thank you. Hard pass.
yeah, I probably want to feel that. Yeah, hard pass on that one. So yeah, our CRNA, which is a nurse anesthetist.
They are so badass, by the way.
Oh, they're just the coolest people, by the way. If there's any CRNAs out there, they are just fantastic.
They are the anesthesia version of nurse practitioners, but they go through, like, they get their master's degree or higher,
yes.
And they do all the anesthesia and drugs and intubations and stuff, and it's an insanely difficult schooling, and they're very, very cool. Anyways,
highly educated, highly experienced professionals. So we had a CRNA who was working in conjunction with their anesthesiologist, and our CRNA, who was a straight badass, is like, "Whoa, let's take care of this," and moves immediately to go ahead and put this woman under.
Hell yeah, just knock me out. Right. At that point,
knock her out. Like, oh, that sucked. Sorry about that. Let's just put you to sleep.
All the drugs. Give me all the drugs.
You get all the drugs. Night. And he was stopped by their CRNA. I mean, by their anesthesiologist.
Oh.
And they were like, no, we're not going to put her under. And he was like, what?
Excuse me?
And so their anesthesiologist just put an oxygen mask on her face.
Oh, honey, no.
Yeah, my understanding is, and I could be wrong, but my understanding is oxygen typically does not have a ton of analgesic properties.
No, well, a lack of oxygen does.
Right, yes.
A complete lack of oxygen.
Right. So she just, lay there and screamed through the oxygen mask. And that was like horrifying for me. It was horrifying for really all of us that were involved in this. And I couldn't help but think it was because she was getting the hysterectomy, honestly.
Were there any female providers of the host nation there?
No, there were not. I think there were some of the OR techs were, but none of the surgeons were. And I couldn't help but feel like our anesthesiologist disapproved of her surgery, of her having
the host nation
yes.
anesthesiologist.
I could not but feel that the host nation anesthesiologist disapproved and wanted her to suffer. And so that was absolutely horrifying.
Yeah, that's
right. Yeah, you want to get your uterus removed? Oh yeah, well you know what? You go ahead and suck it up.
How old approximately?
You know what? I can't remember, to be honest. I don't think she was that old.
Childbearing age still, maybe?
She was probably still within childbearing age. The childbearing age. I don't think she was older than. She was probably mid 30s to early 40s ish. But I believe she'd already had a number of children.
Not that there is any excuse ever for being treated that way.
No, there's absolutely not. This is the kind of shit that would never fly here. I really hope this would never fly here. But you know what? There's nothing we can do. There was really nothing that we could do about it. And I think that was so frustrating because we had the drugs. They were already laid out. Like we could have just put her out and resolved the issue. But
what are you going to do? Start an international incident over this? I mean, you can't.
Yeah, it's a tough call. It's you have to be respectful of the host nation and their policies and their healthcare professionals, but at the same time, it goes against everything that you have in you as not just a healthcare provider, but as a human being, and especially as a woman to watch that. It was pretty tough. So
yeah, I mean, we always say do no harm, and that is very much harm. That physical and psychological.
Yeah, that incident felt really harmful. And so our CRNA, who is a straight badass, honestly, like so stoic, never got flustered.
Yeah, I know this guy. He's so chill.
Yes. He is. He's such a professional, and he's just fantastic. And,
I've never seen him mad.
I have never seen him upset until this moment, and I've never seen him upset since. And he put down his tools. And he walked out of the OR and he never came back. So, I mean, he didn't just abandon the OR. There wasn't an anesthesiologist in there who was running the show.
Poorly, but yeah.
But it was still his show. So that was...
I think at that point, you can't help the situation and you can't make it better.
So he just didn't want to be a part of it anymore, which I found totally understandable. Yeah.
Right. And disagreeing with the team, you're not going to win in that situation. Any disagreements would just prolong the time that woman is suffering, prolong the time that she's open and the incision is open. It would just make things worse.
Right. And conflict between the providers would not have helped. A big part of patient care is, reassuring them and treating, anxiety and stuff. And so conflict between those two providers would have definitely, I think, probably further upset the patient, and it wouldn't have helped her. So I think he probably made a good call in just walking out.
Yeah. And you don't want to watch that.
No, not at all. Not at all. And
for your own mental health.
Right. And so I'm just standing here and I'm, just this little medic. I don't know what's going on and I'm horrified. And, later they were like, by the way, that stuff does not happen in the US. Everyone here would lose their jobs if that happened here in the US. And
oh God, you hope so.
Yes. Yeah. So that made me feel better. It was quite an experience.
But you know what? Moments like that, and you get glimmers of terrible things like that in the US too. Not nearly as egregious as that, but I hope not. I mean, of course, there's always bad things that are anomalies that do happen. But when you see terrible things happen in medicine, it really solidifies your ethics as a provider and who you want to be as a caregiver. So whenever you see someone having a little bit of suffering, or you see another clinician that's kind of going out of control a little bit, you remember these egregious moments. And I think you as a nurse, and then as a future nurse practitioner, you're going to be like, oh, fuck no, and put your foot down whenever it gets even remotely close to something like this again. So there's some silver lining in that terribly dark cloud.
And you know what? They're like, this obviously happened in another country, but that's not to say that women and women of color, and in particular, do not suffer discrimination at the hands of providers here in the U.S. So
yeah, we have our maternal death rate is shameful, especially for women of color.
Yeah.
They have a disproportionately high fatality rate here in the U.S., and we have the highest maternal death rate of any developed nation.
Right.
And it is significantly higher for women of color. Right. And there is not enough being done to combat it. And it's healthy women, it's educated women of color. It's a problem.
Right. And there's not even enough being done to recognize it. I mean, look at Serena Williams, just had a baby and almost died because her providers, she had a PE, she had a history of PEs, and she kept
pulmonary embolism.
Huh?
Yeah. Pulmonary embolism.
Yeah. So she kept telling him, I'm having a PE. This is a woman of color who's very famous, best athlete in the world, and with a history of PEs. And she kept telling them, something is wrong. I think I'm having a PE. And they didn't listen to her, and she almost died in childbirth. So there's not being enough done to address it, and there's not even being enough done to talk about it. There's not even enough effort being made to discuss this and recognize that it's a real issue. So that's just something, to think about as you move forward in your career. Like, yes, this was a horrendous example of discrimination against a woman because of her choice, the choices she's making. But remember that it doesn't have to be that horrendous or that egregious to still be an issue. There are little things that we do, providers, that we don't even realize that we do, probably, that discriminate against people, because of a number of different reasons, because of their color, because of their gender, because of their personal choices, because of their religion. And it's just something to be aware of.
Yeah, I think every time, you walk in to see a patient, you kind of have a little bit of a prejudgment about them, whether you want to or not. And you learn through your career how wrong you are. And I'm probably going to do a whole episode on times when I judged the shit out of a patient and I was so horribly wrong. And I learned a lot of lessons because I could do a whole episode on it. And I hate myself in that moment, but I absolutely love those teaching moments for myself because I've grown so much from them. And we need to be more, open to those teaching moments as a profession.
Right.
Look, doctors are not just old white men anymore. There are so many more providers. There's PAs, there's NPs, there's midwives, there's a lot of other people in this industry. And they're women of color, they're gay men, they're everybody. We need to have healthcare that is representative of the populations that we are treating.
Right. And it's something to be aware of, something to think about when you're treating a patient. Like, do I have biases, and, how do I prevent them from affecting my judgment and my treatment plan?
And it's also important to keep in the back of your mind, if you are in the United States or a developed country and you're treating someone that's an immigrant, maybe that woman that you saw in that OR she's come here and she doesn't trust you as a provider because that's the experience she had back home.
Absolutely.
So we have to be very culturally appropriate. I know a lot of times people go, oh, I don't like this PC bullshit. Well, no, in medicine, we need to be very politically correct, and not just politically correct, culturally sensitive, because you never know who is coming from where, what kind of history they have, and what kind of interactions they've had with any healthcare system prior to their stepping into your realm.
Right. Absolutely.
That was a great story.
Thanks.
Thank you so much for sharing it.
Of course. Yeah. I mean, it's, I think it's just important to remember, like, just, hopefully nobody has a story that bad from here in the US, but things like that do still happen. And,
I was talking about how depressing last week was, and I was hoping that this would be a little bit lighter, but
also depressing. Sorry.
Well, maybe not as depressing. I don't know. I guess it depends. The first week started out real strong with the comedy.
Yes. Oh, speaking of comedy. So you told your snake story, and I love your snake story. And every time Christine and I go out together with a group of people, or even if we're not drinking, I will make her do this sober. I will make her tell them the snake story. And I was like, hey, remember the time that you were working and that woman in the swamp threw a snake at you? Can you just tell us how that, the woman with the snake, could you just tell that for us, please?
It's my party trick.
Yes, it is your party trick. And it always makes us laugh. But you actually had another incident with some snakes.
Yes. So I told the snake story, which is the flying snake story, like a million times. And then very recently, I was telling you, actually at a funeral.
Yes, you did. You told us.
Because why not, right?
Right.
About a fire that we had been to. So whenever there's a fire, the ambulances are there, and you just kind of hang outside, and hopefully you're not needed. But this one was for a guy that was a reptile breeder. His building or house caught on fire, and so the whole house was basically ruined. The whole house kind of burned down, but not completely burned down. So at the end of every fire, when everything is knocked down, they call it, the fire's out, they do my favorite part, which is called overhauling, where they take everything that is inside and it all goes outside. So it all just goes out through the windows. So the couches and chairs and everything just gets thrown out the windows.
Why do they do that? So
they're looking for hidden fire. They want to make sure that the couch isn't on fire and it's going to rekindle and the whole place is going to go up again. They want to make sure that they got the whole thing. It's really out. It takes a little while. So they throw everything out, and I don't know what they're doing in there. Maybe they're having a party, but it looks fun. I just sit outside. They do all the work. It looks exhausting. So this fire was at this guy that had a lot of reptiles. I don't know if he was a breeder. He was just one of those collectors. I don't know. But all of a sudden, all of these burned snakes start flying out the second story windows. And me, who had been at this goddamn fire for hours on end, was like, oh shit. Oh, now I'm paying attention. Because of course you're bored out of your mind. I mean, as EMS, you're not really doing anything. You're just standing around and you smell like smoke, and it's like, you want us to be bored at these things, right? If we're entertained, we're working, and that's bad for firefighters and bad for people. So all of a sudden, all of these snakes get thrown out these windows, and they're dead. I mean, which is, I would say, tragic if it was any other animal, but obviously my feelings on the snakes are pretty clear at this point.
Right.
And it was just raining burnt snakes from this house, and I was just like, what the fuck is happening?
It was like your ninth circle of hell, just charred, flaming snakes raining down on you out the second story window.
Well, thankfully I was across the street and they weren't coming at me, and they were dead. They weren't flaming and alive and slithering towards me and like coming right down on top of me, because that would have been just
That probably would
awful.
not have been a good day.
Yeah. I mean, nobody wants dead animals. Don't sue me, PETA. But yeah. It was just like, what the fuck? Why can't I? This was after the snake story had happened.
Right.
So I was like, I can't get away from this shit.
This is like some nightmare fuel.
Yeah. But like, I don't know what they would do. Like, you can't go into a house and be like, oh, look at all these snakes. And like, you're not going to rescue them like a bunch of puppies, because what if they're venomous?
Well, yeah, that was my first thought. I was like, well, you can't just discriminate against the snakes because they're snakes. But, puppies aren't typically venomous, to my knowledge, unless there's, some new breed out there. So I guess that's pretty understandable.
Well, I feel like that's a hazmat situation. If there's like a bunch of snakes. No, I mean, I'm making a joke, but it's kind of serious. Like if there's like a snake breeder, I feel like you'd have to notify the fire department if your place goes up and there's like these snakes trapped in these cages. Like, they must have evacuation plans and all this kind of stuff.
Well, apparently.
I imagine that it was their evacuation plans for like a legitimate snake breeder would be a little bit more in depth than like, those little stickers that people have on their doors, like, hey, fire department, there's 2 cats and 1 dog in here. Like, I don't think they just have like one of those stickers that's like, there are 4 boa constrictors. They're okay. You can get them if you can catch them. There's 1 rattlesnake. Fuck that guy. The iguana's cool. Bring him out. Like, I don't think that is on their door.
It should be.
Like, I don't think in a fire you're going to like worry about the snakes. I think you let them burn.
I mean, yeah, I probably would not go in to rescue some snakes. Puppies, totally. Cats, absolutely.
Yeah, sure. Mammals, great.
For sure. Mammals, absolutely. Anything that slithers is probably on its own.
Well, geckos, you like? No, chameleons.
I do. I would probably rescue a chameleon because they're pretty cool. They have cool little mitten feet and stuff. So
yeah, but imagine if they were like loose in the house and then you went in there.
Chameleons, yeah, for sure.
And it was on fire. No, not chameleons. Oh, no, a house full of chameleons? That'd be kind of fun. No, a house full of like flaming snakes that were alive and you were like a firefighter and you had to go in there. Ugh.
I'm pretty sure that's actually somebody's nightmare.
Yeah, mine.
Oh my God. Well, thank you so much for inviting me on your podcast. I really appreciate it.
Thank you again for coming on, and thank you everyone for listening for another week of Antidotes. If you like what you heard, please give us a review on iTunes, leave a rating, write us a little note on there. It helps with our boosting and getting more people to listen. If you have a story of your own, you can always send us an email at antidotespodcast@gmail.com. Give us a follow on social media too. Our Facebook is Antidotes Podcast, which is the same as our Instagram, which is Antidotes Podcast. And our Twitter is Antidotes Pod. You can follow us at any of those sites. And hopefully we will be back next week with another story, which again, I do not know what it is. So we will both be surprised. Have